I'm trying to get this here. Okay. Are you hearing me? Yes? Hopefully. Okay, right. So we will conclude today what we discussed last time, and we'll move a bit on the genetic counseling. Over the uni years, you'll be exposed to this term in many circumstances because you will face different kind of pathologies that can be monogenic or polygenic, chromosomal or mitochondrial, and you need to do genetic counseling. What means counseling? You have an idea what it means to counsel someone? To tell him, and what you tell and how you tell counts, right? Maybe we are more familiarized with the psychological counseling when we go to a psychologist and we discuss with a professional, and then we get insights of our life and how to solve problems. So genetic counseling, it's something like that too, right? But as a psychological counseling, it's done by an expert psychologist. The same genetic counseling shall be done by someone who is trained into that. It's not just I will tell you about, right? Okay. So it's the way in which you communicate regarding why that disease happened, what's the mechanism, what is the risk to happen again, and how we can manage the case and how we can prevent a case to happen again, right? So the main thing in the process of the genetic counseling is starting with the diagnosis. So first of all, you have to have a diagnosis, otherwise what will you counsel about, right? Then you will discuss about the management and prognosis, the mode of inheritance, how we can estimate and also how we communicate risk. We'll discuss about that. Which are the options available to identify the risk or to avoid the risk, and how you maintain a contact with the family or the patient or the proband, and how you do the follow-up. So you can counsel genetically individuals in different aspects of their life when you have a person affected by something or a family who has a child affected by a genetic disease or something that was born with. Of course, you are beautiful and young people. In some years, you will consider building your own families, right? So we do also genetic counseling before a couple is deciding to marry, premarital and preconceptional genetic counseling, in order to help people understand if they have risk or not to have effective offspring. Obviously, you need to do counseling before and after a genetic testing. I told you last time how important are these kind of tests, how elaborated they are. They have a lot of implications, so people need to be aware before they do a test what to expect when the result is coming. And also when you have the result, again, you need to explain it and to help people accommodate a positive result, because if it's negative, it's much easier to navigate through. And as I already said, before conception. So either you can do before couple is marrying, or they are already married and they want to have a child. So then you explain them before they conceive a child which are the risks and what they can do to avoid that. And a particular counseling with special emphasis with this in this region, it's counseling in consanguinity. You are aware that the Gulf population has a high percentage of consanguinity, and this is associated with increased risk for recessive disorders, right? So a bit different than communities where you don't have high level of consanguinity. So any person who is doing genetic counseling, it's called genetic counselor. But not any person can do genetic counselor, as I said before. In this profession, you shall be a medical geneticist, so you have a license practicing that, and it's part of your training. I mean, 2 years of intensive genetic counseling in my residency training. Can be a person who has a PhD in genetic counseling or a master in genetic counseling, can come from a medical background or can come from a psychology, biology background and is doing the master and the PhD. And a genetic counselor can work in various settings, of course in pediatrics clinics, in obstetric gynecology, in adult clinics, in public health programs, in research, in public policies, and also in biotech industry and in education, right? So teaching others how to do genetic counseling. So the person who is asking for genetic counseling, it's called consultant with D in end, right? And usually we work in a team, as we emphasize this many times, and you'll hear it till the end of DS6 medicine. It's never one-man show, it's a team. And in genetic counseling, the same. You have the geneticist, the consultant geneticist who diagnosed the case, and then you have the counselor, sometimes it's the same person, sometimes not, who is counseling the patient and the family about the significance of the diagnosis and how to deal with the diagnosis. So there are some stages. Obviously, the first one, you start by building a pedigree, and you are aware what a pedigree it is, right? So you can do, again, the exercise building your own family pedigree, putting you, and then start with you having your siblings and above your parents, grandparents, and then you can go on both arms, right? Your mother's side and your father's side, and build it more. So in order for us to do counseling, we need to have a pedigree because we need to assess the type of inheritance, and we can do that only if we build a pedigree. But we need to have at least 3 generations. Remember that? So 3-generation pedigree. You have to have at least grandparents, parents, and children, because otherwise you don't know how the genes are moving. You cannot assess a type of inheritance, right? Then obviously the clinical examination. This is in the procedure to reach the diagnosis, but generally a counselor per se already has the diagnosis, and he's not doing a clinical examination, he's just building the pedigree and it's explaining it, right? But as a doctor, to reach a diagnosis, obviously you need to do a clinical examination to reach a diagnosis. And as in your problem, we look to the face, we saw dysmorphic facial features, and we assess, oh, this may be Down syndrome. And then we saw a baby who doesn't look like Down syndrome but has different particularities, and we assess that this can be Cri-du-Chat, and then we done testing. Now, it's important to know, and you saw in your problem, you saw a child with Cri-du-Chat at birth, and then as a teenager and as an adult. So the face is changing. Our face is changing, right? If you look to a photo of you when you've been a baby, you look different today, right? So it's important this in medicine, especially in genetics, to look to a person in dynamic when you do not know exactly what the diagnosis is, because the face is changing, right? And a lot of signs and symptoms can appear or can disappear, right? So, and when you do examination, like any kind of examination in medicine, you should do a complete examination. Don't forget. Don't look only to the face, oh, this is Down syndrome. You still need to examine the body, right? Or you have a patient coming with a burn on a hand, you look on the hand, you treat this and you let the patient go. Maybe, right? But not maybe. You need to examine it because you may discover something that it's much more important than the tiny burn on the hand. So always when you have a patient, you have to examine fully. In genetics, you have to repeat the examination in different stages of life, and obviously to examine different members in the same family, because you look for inheritance. You look to see if there are other people with similar signs and symptoms in the family. Diagnosis is very important. Again, without a sharp diagnosis, you cannot do an accurate counseling. And diagnosis, we already discussed, there are different methods and testing to help you reach a diagnosis, being a chromosomal disease, being a monogenic one. And a part of that, you can move out from the genetics. You can do biochemical testing, you can do morphopathology, you can do biopsies, you can do MRI, CT, and so on. So according to what you need and which system it's affected to clarify a diagnosis. But different than other specialty in genetics, you can also use medical photos, right? You know, nowadays not photos, but phones. Ask the parents, do you have other children at home? Yes. Show me, how are they looking? Because they are in the phone, for sure, right? So then you can check how the siblings are looking and to see if they may be affected or not, and the parent is not sensing this, right? Or you can ask the parent, okay, now the child is 5, can you show me the photo when this child was small? Because they have it in their phone nowadays, right? So then you can look in dynamic. So the counseling per se, you have to have the diagnosis. And what is important, ideally, when you counsel a patient, if it's about a child, you have to have both parents present. Because if you start saying to the mom, because of the huge stress, when she reaches home, she might not say what you said, and she forgot. So you need both parents. And what is very important, and that's not only in genetic counseling, it's always when you deliver bad news, you select a time after bereavement or after initial shock. People cannot grasp information when they are in big distress. If a report that just came now positive for a cancer, positive for a severe degenerative disease, positive for a severe genetic disease, you will not counsel the patient immediately. The patient, the family need a bit time, to reset. Because otherwise what you say has no value. They will not understand, right? So that's very important. Now you need to include all aspects of the condition. So therefore you need to be very trained about the condition, and therefore genetic counselings are done with appointment. You don't just go into the clinic and have a patient who came from that. Important is to know what you will counsel, because you need to prepare, and you cannot know by heart 25,000 genetic disorders, right? And different kind of mutations or pathogenic or likely pathogenic variations. So you need to prepare. And plus the information, it's moving from 2 years back from now, new advanced things, maybe new cases have been reported. So then you need to read to prepare before you come in front of the patients or family. But important is how you explain. That's something that over the uni years you have to experience this, and the tutorials are doing that, right? When you come in front of your peers and you present. Communication is very important. You have to explain it in a way in which someone who had nothing, no idea about that will understand, right? And you have to adjust the language accordingly. In this setting, we speak in an academic language, sometimes not very academic for you to understand some things, but still science, right? But you cannot speak science with people who have no idea about, right? If I speak with you about CRISPR and gene editing, you may know what it is, maybe not at this level, but later on. But if I tell to someone we do CRISPR, they have no idea what is CRISPR and what is gene editing, right? So you need to explain. CRISPR, it's a scissor going inside of the gene looks like that. So for people to understand what you refer to. And when you say about the risk, you need to have different ways of explaining the risk. Some people are more into numbers, some people are more objective on the real side, and some people are more subjective on the emotional side, right? So one is to say your risk is 25%, and one is to say 1 out of 4, right? So you have always to have different ways of expressing the risk that you assess it, and always to comparing with the general population. Your risk to have a child with sickle cell disease is 25%. The risk of someone who is not carrier, it's below 1%, right? So then they will understand how you need always to compare with the general population. Right. The most important thing is that when you counsel someone, even if it's psychology, even if it's genetic, you are non-directive. Do you know what means this? Correct. So you are there to deliver information, not to tell them what to do, because otherwise you overpass their autonomy, and that's not correct, right? And they will ask you many times, doctor, but what will you do if you'll be in my place? What will be the right answer? I'm not in your place. I'm here to help you and guide you. But my life, it's not your life. That's the truth. That's the truth. Because if you've been in their place, you may take an opposite decision, right? Not the one that they favor. We are all different. We have life principles. We have different faith, different orientations in life. So then we may take different decisions that are good for us, but not good for others, right? So refrain of saying, I will do this, because it's not correct. You are not non-directive. You're telling them what to do. And because they look high to you, the doctor knows, they will take a decision that might be contrary to their own beliefs or to their life principles or to their wishes. And non-judgmental. The entire medicine is non-judgmental. You are not there to judge them why they want to marry, why they want to have a child. right? Or why they married consanguineously. It's not your job to judge. It's your job to deliver precise, correct, accurate, and updated information, and to help them take the best decision for them, but not to tell them or to question, right? Why you marry at 35? Why you have a child of 42? You should have been having a child of 25. Wow, it's not that. Nobody has the right to come in your life to tell when to marry, when to have a child, right? Or to question to whom you marry or why you had a child, right? So think in that, on the real autonomy of people. You never judge. And not only that you will not say that, but be very careful of your body language and face, what your face is saying, right? So that's very important, and you shall practice this over the years. I already said that, right? Very accurate, and you have to respect autonomy. So, autonomy, the couple shall take always their own decision, or the person, right? If it's a child, will be the parents. If it's an adult, himself. The decision is based by the information you give it, right? It's an informed choice. Okay? And shall be an informed consent. Anything you want to do, I want to do a test, I want to prescribe this, you shall take the consent. And the consent, it's written, right? It's not, yes, I want, or no, I don't. It shall be documented how you prove that you've done it, if you don't have on written black on white. You know the Latin word, verba volent scripta manet. The word, it's flying, the spoken word, it's flying, the written word, it's remaining. Yeah? This is from Latin. And of course, confidentiality. Again, very, very important principle in medicine, and again, it's in genetics there. What the patients or the parents are telling you, it's remaining there, right? And many times, they tell you things that nobody else knows in the family, right? So keep in mind of that. As I said, you need to compare the risk with the general population. I just presented for you, for your knowledge. Nobody will ask you things like this. But it's important to know, again, you are young people, in years to come, you would like to build your own family. So these are pathologies that happen to all people all over the world. So 1 in 6 pregnancies, it's lost spontaneously. So if you have couples with miscarriages, you will tell them this, right? Because they need to know, oh, it's happening only with me, doctor. Why it's happening? No, it's not happening only with you. A lot of people all over the world may lose their first pregnancy till the body is adapting with the hormones and all this. Now, 1 in 15 newborns are dying all over the world. We don't know exactly why, right? And 1 in 33 are born with a major congenital anomaly, being the heart, being the kidney, being the GI. 1 in 50 people all over the world are having a serious physical or mental disability, right? And you know already that 1 in 4 people at the adult age, after the age of 65, it's having a risk to develop a cancer, because we all get old, right? And the cells division is affected. So some things we need to pay attention to. I call them misconception about heredity. People are thinking that if there is nobody in the family affected by a genetic disease, then there is no chance that a genetic disease can appear. And opposite, if there are people affected with a genetic disease, all other siblings in the family will be affected. No, it's not like that. So, you know, genetic disorders can appear by spontaneous defect. So nobody in many generations had ever had anything, and suddenly a child with Down syndrome, it's happening, right? Or with cystic fibrosis, or with achondroplasia. Any condition present at birth must be inherited. That's not true, I just said, right? It's not necessarily to be purely genetic. Genetic diseases are untreatable. Absolutely false. All disorders in this earth are treatable, but not all of them are curable. Which is the first treatment for any disease in any circumstance? No. Which treatment will be for any disease? What will you start always? No, because not all disorders are having pain. You start with diagnose, but before you start with the diagnose, you do something else. You understand, right? You understand what? You understand the disease. You are close, but not very close. The first treatment in this life is, good morning, my name is Dr. Ahmed, I'm here to help you. That's the first step. You shake the hand, you present yourself, I'm here to support you. That's the first step of a treatment. In the moment when you create a bond, a connection with your family and with your patient, that's the first step for a treatment. You'll gain trust, you'll gain respect, and then there will be cooperation. You can do whatever test, but if you don't present yourself and you don't explain yourself, that will not be a good treatment. That patient will never come to you again, right? So all disorders are having treatments. You start with presenting yourself, right? And nowadays, genetic disorders are indeed not only treatable, but also curable. We have some cures for some disorders. We have gene therapies for some disorders. Hopefully in the years to come, when you will become my age, many, many disorders will be treatable. Upsets mental, physical of the mother in the pregnancy cause malformation. That's not true. If only males or females are affected in the family, this indicates sex linkage. No, with some exception. If you have only boys, there might be an Y-linked disease, right? But you may have boys and girls and can be an X-linked one. It's only available for Y-linked. And these are not serious disorders. And that's something very frequent. A 1 in 4 risk means that the next 3 children will be unaffected. You will be surprised how many people believe that. And they went ahead having other children and all of them got affected. And then they got in huge panic. How come? They told us it's 1 in 4. We got 1 affected. Why we have the rest of 2 or 3 affected? It's 1 in 4 for each pregnancy because at each time will be a new spermatozoa with a new oocyte, new genetic code, right? Incorrect and incomplete diagnosis will lead to an incorrect counseling. Then genetic heterogeneity, and that's complicated. We go more in genetics. You may have a disease which is caused by changes in different genes, right, and looks the same, and you need to know that. Then non-penetrance and variable expressivity, we learn about that when we discuss more about monogenic disorders. Some disorders manifest very variable. You may have in a family 3 siblings affected by the same disease, but they are on different degrees of severity. Some are very severe and some very mild. Nobody even thinks that they are affected, right? And non-penetrance means that sometimes a disease can escape a generation. I mean, a person has the change, but it's not manifesting it. And his or her children will have the disease. That's a bit complicated, we'll discuss later. Inadequate knowledge of the literature, that's very important. That's why I said counseling, it's done with appointment. You need to prepare yourself before. You cannot just jump into if you didn't read everything about that disease, right? Because family, patients will ask you, doctor, is it any treatment? Is it any center in the world where I can go and do something? Is it something new? Can I do that? Can I not do this? So you need to read about the disease. Can I keep, I had a patient with achondroplasia, Dr. Samira is with us, so then she knows what achondroplasia is. It's a disease where the humerus and the femorus are very short. These are the dwarfs. You see them sometimes on circus, right? But then they are normal people like us with normal intelligence, but their femurs and humerus didn't grow, right? So they have the head a bit big, so therefore they have some instabilities in this joint in between the atlas and axis, right? Exactly like in Down syndrome, they also have the same instability. So I had a father who called us almost each day, doctor, can I keep the child like that in the car? Is this chair seat, is it good? Shall I buy another one, So you need to read to know how to tell, because people are going into big stress thinking that they don't take care well about their kids because they may harm the kid, right? So if you are not prepared, you will do not know what to answer, right? So they had to keep the child like that, right? Not like this and not vertical because there was too much pressure into, right? And not to jump with the child. So simple things, but if you don't read about the disease, you will not know. The same it's in Down syndrome. A person with Down syndrome can never do this as a child because of instability. So you will not let a child jump on a trampoline. But if you don't read, you don't know. So you'll not be able to explain to the parents, right? And sometimes you are facing a very new disease and you have no idea about. Gonadal mosaicism, we discussed about mosaicism, right? We said that the syndrome can be in a mosaic form with normal and abnormal cell lines in one person. Gonadal mosaicism means that, for example, the mom or the father has some germ cells with a change and others are normal. But it's difficult to know this. So therefore, because you cannot go inside of ovaries or inside of testes to test all spermatozoa or all eggs. You cannot do that. So therefore, the recurrence risk in all disorders, it's never zero. Because even if it's an accident, for example, if it's a child born with Down syndrome and the parents are healthy and young, not above 34, not about 35, not about 45, right, in a man, and it's the first child who is born with Down syndrome, you will not say the recurrence risk is zero because it was an accident and this couple are both 25. The recurrence risk is somewhere around 1%, 2%, because you do not know, maybe the lady or the gentleman may have in the gonads some cells with abnormal. It was not only one cell who got an error, might be more. Right? And the same is with the monogenic disorders, right? A mutation, a pathogenic variant can happen spontaneously and can happen either in the sperm, either in the ovum from which that person was conceived. But you do not know if have been more sperms in the testes or more eggs in the ovaries of those parents with abnormality. So the risk, it's never zero. Keep this in mind. So how you can assess a risk? By two ways. You can quantify and you can qualify. Can you see the difference in between a quantify and qualify? Quality and quantity? Do you know this difference? You perceive it different? Okay. So when you quantify, you express it mathematically. When you qualify, you are expressing according to the impact in the life quality. Yeah? Severe, mild, normal, very severe, lethal. This is a qualification of the risk. A quantification, it's 1 out of 2, 50% in monogenic disorders, autosomal dominant, right? In autosomal recessive is 1 in 4, 25%. Again, I said this, apply to each pregnancy, right? That the chance does not have a memory. In X-linked recessive, it's 50% for the carrier females to have an affected son. You'll learn this later on, right? But I'm just giving you some examples. According to the heredity, the risk vary, right? In chromosomal disorder, because this is our problem, the risk vary from 1% to 100%. When is the risk 100%? When we have what? A translocation, 21-21. That will be the risk of 100% having a child with Down syndrome. It's rare, but it's 100%. You cannot tell to a gentleman or a lady who has a translocation Robertsonian that, okay, it was an accident, you'll have new pregnancy, maybe healthy. No, right? So that's very important. In multifactorial disorders, the risk is in between 2 and 5%. So if a child is born with a cardiac defect and has no Down syndrome, nothing else, it's just an atrial septal defect, the risk to have another child, and no parents had anything, the risk to have another child, it's double, right? So it's not 2%, it will be 4%. It's not 2 to 3, it will be 4 to 6, right? In consanguinity, the risk is increasing. You always add 1%. For any congenital abnormality, the risk is around 5%, as I said. And if it's a consanguineous family, then the risk is increasing up to 6%. So, like, if two people are married not consanguineous, their risk to give birth to a child who has only one kidney, like all over the world, is 2 to 3%. We all have this risk. If the couple is consanguineous, the risk is 6%, because there are a lot of genes in common who may interfere into the kidney development. Okay? So this is with the qualification. What you need to explain on the counseling. The nature of the long-term burden. Down syndrome, it's for life, will not be cured tomorrow, right? The severity of the disorder. Down syndrome, it's a severe disease. IQ is severe mental retardation, it's very low. And if they have cardiac anomalies and other things, can be very severe and they can die in the first years of life. If the condition can be successfully treated, right? In many circumstances, a person with Down syndrome can be very well managed medically and reach 65 in a very well condition, right? If the condition is associated with pain and suffering, it's different. Even if the risk is 5%, if it's leading to pain and a lot of suffering, the quality of the risk counts more than the quantity, right? If prenatal genetic diagnosis is available, because they want to know, can I avoid this to happen again? If pre-implantation genetic diagnosis is available, and we'll discuss over the years about these two different things, right? Prenatal diagnosis means you diagnose a pregnancy that it's ongoing, and it's involving if the pregnancy is affected, what will you do? What decision will you take? Will you keep or not? So a lot of ethical issues and legal issues. And in pre-implantation genetic diagnosis, you test the embryos before they are transferred to the uterus, so there is no ethical thing. I will finish with this. So I can take just 5 minutes. Thank you very much. Sometimes it's difficult to calculate the risk. So you need to gather a lot of information. You need to read a lot about. You need to take a lot of information from your team and also from the parents. But what I want to deliver for you is that it's a worth effort to do that, because finally you'll be able to help someone. And what is important is to split two things. The process of calculating the risk, all assessment, starting from examination, pedigree, diagnosis, testing, and all this, shall be done very rational, extremely accurate, and at cold. That means cold, right? The risk is calculating at cold, precisely, right? But how you communicate shall be very warmly. I mean, 2 + 2, it's always 4. Trisomy 21 will be always trisomy 21. You cannot change that. And you have to have evidence proved. You have to do karyotype, you do FISH, you have PCR or whatever to confirm it. Very precisely, very cold. But the way in which you explain to the parents that they have a child with Down syndrome cannot be cold. This is the diagnosis, your child has Down syndrome, this is the karyotype, I can see you in 1 year, and you leave. That's very cold, it's very rude, it's very harming. Shall be very warm. What was on your problem? They observe it immediately, the parents observe something, it's not okay, they ask immediately what the medical team said. We need to do some investigation, and then we'll discuss with you. Why? Because I need to be cold on assessing. I need to be precise. I cannot give bad news with long-term severe consequences without having strong proofs. And I cannot harm these people just like that because I believe something it is. I need to have proofs. And then what is written in their problem, they've been sent where? To genetic counseling. It's not I'm telling you it's this. Let's discuss in a proper setting. Let's have time to introduce ourselves. Let's see what we found. Let's see how we can help you. Let's explain why it happened and how we can manage this risk and how we can manage now a diagnosis, right? What we can do for your child with Down syndrome. How we can help you to raise this child good, right? So shall be very warm. So what we all need in this profession, a part of science, knowledge, and communication. Emotion. Empathy, I will say, because if you are too emotional, then you can lose it, right? You shall be empathetic, I mean to resonate with people, right? So there are two different things, emotion, empathy, and sympathy. So just try to make the difference in between, right? So I already said that it's so important how you communicate, how you tell someone something that it's not okay. And you learn over uni years to break bad news. There is a procedure, there is a sequence of doing that. You need to prepare before that, you know, it's just like this, right? And you'll be surprised, us, after such many years of practice, we prepare before we deliver bad news. We really prepare. I never go into the clinic to deliver something very bad who has lifetime consequences without preparing and thinking how I will say it, how I will say it in a very warmly way, in a very respectful way, in order to help them navigate with ease through this very difficult time, right? Okay. And also what is important in counseling, like in all medicine, it's not only to communicate, but your capacity of knowing when not to speak. to listen. There are moments when you just need to listen what people are telling you. If you just say, and you don't give them the chance to express, then you lose it, and they will not come again. This doctor just wants to hear about himself. I do, I am, I can, I this. Refrain yourself of putting always I. Immediately it's saying that your ego is still ahead, till the sky. You are not there to impress people. You are there to help people. And you will impress them by your knowledge and attitude, right? Be aware of this, okay? So use the term chance instead of risk. Provide the risk in different formats. Consider using natural numbers. It's much easier for people than saying numbers than saying percentage, right? Give the chance for good outcome also as the bad outcome, right? So it's this procedure asking, what would you like to know, the good news or the bad news first, right? So many of us want to hear the bad news, but others are saying, no, start with the good to prepare myself, right? So there are different techniques you learn over the years how to do that. And put the risk in context by comparing with the baseline and the community, right? So different indication, we discussed that, a child affected, a child isolated with a birth defect, family history of hereditary condition, prenatal diagnosis, relatives who had cancer, a lot of conditions that will come to you for counseling later on, right? Consanguinity, teratogen exposure, right? A pregnancy exposed to radiation or chemicals, a lady young who was using a lot of retinol cream for her face without knowing she's pregnant, and then she's reading on the Google that the retinol, it's highly teratogen and it's coming to you, say, doctor, is it something bad now with my child? I just found out I'm pregnant and I use a lot of retinol and so and so. So this is teratogen exposure. So plenty situation when you will do a genetic counseling, right? Repeated pregnancy loss or infertility, a new condition in the family, before the test and after the test. So there is a procedure in how you need to all look on all this. We already discussed that. And that's an example how sometimes genetic counseling can be extremely complicated. This is a family with cancer, right? Imagine counseling an individual like that. It's from a family like this. You need to prepare a lot. And I will close with that, and that's my message since years for all medical students. Remember why you are here. Remember why you want to become a doctor. And remember that you came here to become an excellent doctor, not just a doctor. And remember that you have two hands. One is to help yourself and the other one is to help others. Otherwise, if the Creator wanted us to manage with one hand, we could have been having only one, but we have two, right? Think into that. In this profession, you are here not to harm and to help. And through counseling, you can help a lot of people. But if you do it wrong, you can harm a lot of people, right? So think into that. Thank you very much. If we have questions, I will answer gladly after Dr. Samira talk.